I'm just going to launch into my talk since I probably overstacked my slide deck. So I'm going to talk about surgery for mesothelioma and is there a future, because there are a lot of things that have been developing over the last probably 6 to 8 years with medical treatment, including targeted therapy and anti-angiogenic therapy, which we're going to hear about in a while, and also immunotherapy, which is something that's this year been coming to the forefront. So a lot of things have been changing, and people have questioned for a while whether surgery actually accomplishes anything, and so I want to kind of address some of those points. So I do have one disclosure, as I'm an unpaid scientific advisor for the Pacific Heartland and Blood Institute. So what I'm going to talk about is some data and some observations that argue against the use of surgery in mesothelioma. Then I'm going to talk about some supporting evidence that we have that we can use to help support surgical programs. However, there are no really completed randomized studies, so we can't really say anything for sure. And we have some unique opportunities, though, I think, if you think about things that ongoing for the future where surgery actually can play an active role. So the first thing I'll talk about is the arguments against the use of surgery. So there's certain surgical oncology principles that are kind of defied by using surgery in mesothelioma. I'm going to talk about those. We're going to talk about some results from the MARS-1 in particular, but some information about the MARS-2 trial that are going on, and then the improving non-surgical options, particularly MAPS-1 and 2. So if you look at the R classification, in the TNM system, there's an R classification. This applies to actually all treatments, and you have an R0, 1, and 2. So after any treatment, you can assess the patient for this R status, and R0 would be there's no residual tumor, R1 would be microscopic residual tumor, and R2 would be macroscopic residual tumor. It's easiest applied to surgery, so I think surgeons have applied it most often. But it's easy to see that if you have microscopic residual tumor, there's no macroscopic tumor. You don't need to invent other terms like macroscopic complete resection and everything. All you need to do is use the terminology in the TNM system. So that's what we do. And it's not specific to therapy. You can use it for chemotherapy and radiation or any other therapy for that matter. And it applies to any tumor and any site, and it also includes looking at metastatic disease. So if you're operating on somebody and they have a brain metastasis from a lung cancer, for instance, it's still residual disease, so in the brain. And then you take that into account, not just the surgical site. It's been standard in the TNM system since 1978, and is in the current fashion, it's actually since 1997. All right, so surgical oncology principles for curative surgery for almost any cancer. You really need a complete en-bloc resection. So R0 resection is all that really matters. So unfortunately, that's not usually what we do in mesothelioma. R1 and 2 resections really have no support in the literature for almost any circumstance, although there are supporters in ovarian cancer, retroperitoneal sarcomas, and maybe mesothelioma. So this is really the reason why. This is the kind of a diagram from the anatomy book from the inside of the chest. This is the left side, this is the right side. And you can see a lot of important structures here. The lung is gone, but the pericardial sac and heart is here, all the big blood vessels, the nerves, the vertebral bodies, the esophagus is back here, right in here, on both sides, and the diaphragm, so all in the chest wall. So these are all the things that actually touch mesothelioma tumors when you operate on patients. So if you were to technically do an R0 resection, you have to take all these things out, which obviously is not possible. So when you look at the resections for mesothelioma, you really typically are trying to get an R1 resection because you know you're leaving microscopic residual tumor. Occasionally you have to settle for R2 resection, and R0 is basically highly improbable or really impossible. So now I want to talk about some of the surgical trials of MARS-1 in particular. This was kind of, at the time the MARS-1 kind of came out, this was the gold standard report from David Sugarbaker looking at 183 patients published in 1999. At that point, there was no standard chemotherapy, so they gave a whole gamish of chemotherapy regimens and then did radiation in several different approaches and looked at their patients. Interestingly, they had pretty low mortality, but they deleted these mortality patients from the survival data, so it's a little bit skewed. but their median survival was 19 months, which was a lot higher than any other treatment at the time. So the trimodality type therapy became kind of the gold standard for the period of time. However, there were some people in the UK in particular, Tom Treasure and others, who were kind of questioning whether this radical operation actually was accomplishing anything, or just selecting out the best patients for the longest survival. So they started the Mars 1 trial, which was a feasibility trial that was supposed to randomize at least 50 patients in the first year in order to make sure that the trial was actually feasible in terms of the final outcomes. And unfortunately, it took them over 3 years to randomize 50 patients on the trial, and had to go through 301 patient screening in order to find those 50 patients. So it wasn't considered a success. It was not feasible to do this trial. It didn't seem to work. But they looked at some of the results and published them. And what they basically did is, one assumption which can be questioned is that they assumed that induction chemotherapy was important, because that was what was being worked on at the time, even though there was no basis in any reports to suggest that induction chemotherapy actually works. So they included induction chemotherapy, and that's one reason why they had to go through so many patients in order to get 50 patients, because a lot of patients dropped out from the chemotherapy. They did EPP and XRT. So, interestingly, they randomized 24 patients to extrapleural pneumonectomy and 26 patients to no surgery at all. However, they only completed surgery in 16 of the 24, and the 8 that didn't get it for a variety of reasons, including one intraoperative death and clinician choice, patient choice, and unresectable disease. In the no surgery group, 5 still anyway had EPP off study, and 1 had a PD. So if you look at the crossover rate, there's at least a 20 to 23% crossover rate in both sides. So it's hard to make anything of the ultimate median survivals for both these groups, with the EPP being actually fairly low, lower than traditionally seen at 14 months, and the no surgery group way higher than the traditional seen at 19.5. These are the survival curves with the EPP, the radical surgery, below this, and the quality of life curves were much similar, in the EPP being below the no surgery arm. So some people use this, and even now use it to say, well, surgery isn't really helpful, it's actually worse. But there's a lot of problems with that. So the Mars 2 trial, we're trying to do actually a more modern trial and look at parectomy decortication in the same way. So for this, they're planning on doing cis-pemi for 2 cycles. Again, induction chemotherapy, I'm not sure why people are caught up on that, because that's not necessarily useful. Then PD, and then cisplatin pemi for 4 cycles afterwards, versus just 6 cycles and no surgery. So they said again they want to do a feasibility portion of this, and they had to randomize 50 patients over 24 months, but they actually made it 5 months early. In 19 months, they randomized their 50 patients, and now they're currently been moving on to the next phase, which is to complete the trial with 326 patients planned over the next supposedly 3 years. So we'll see in a follow-up of 2 years after that. So we'll see in about 3 to 5 years what some of the data shows. So against this kind of background, you have to look at what else is happening, and there's improving non-surgical options all along the way. So this is kind of the 2003, Nicholas Vogelsang published this paper, which is an Eli Lilly trial with pemetrexed and cisplatin versus cisplatin alone, and these are all the information from it. But the bottom line was that that when you look at the survival curves, the cisplatin and pemetrexed arm, both in disease-free and overall survival, was better by almost 3 months, from 9.3 to 12.1 months. And so this became the de facto standard, and then the question was, how does this interact with surgery? More recently, from France, there's been a MAPS-1 trial. I like the maps. You have to fit everything into a map, so I'm not sure how it actually fits into maps without 2 Ps, but this was a trial looking at Avastin or bevacizumab in addition to the cisplatin and pemetrexed in a randomized trial, and this was actually a pretty good trial because they randomized 448 patients over just over 6 years, which is pretty good. And the 2 arms were pretty well balanced. There was some grade 3 or higher toxicity and hypertension, and some minor some thrombotic events, although it's a relatively small number of 6% in the bevacizumab arm and only 1% in the other arm. So the overall survival, however, was better, significantly better, again with the 3 drugs than the 2 drugs. And this is almost the same as the pemetrexed trial, where it's almost 3 months more. However, you can see that the survival in the pemetrexed cis alone arm was actually much higher than the previous one. So people are, 16.1 months rather than the 12.1 months that it was previously. So this is probably just from treating different patient groups. So it's not necessarily that one trial has had better outcomes. It's just you're treating probably earlier patients. That's all. But in addition, here's the survival curves. In addition, there's kind of a little tail here where people are surviving over 5 years, which is something I'll talk about in a little while. So recently in ASCO and ESMO this year, there were presentations on immunotherapy. And this was now in the MAPS-2 trial. Now it's mesothelioma anti-PD-1 study. That's the MAPS part. Done again in France by the same group, and they are getting this thing down now because they looked at the nivolumab PD-L1 inhibitor versus nivolumab plus the CTLA-4 inhibitor, ipilimumab. So this is a very interesting trial, and this is done in the 2nd line and 3rd line setting, so this is after chemotherapy. And the goal is to see an increase in 40% disease control rate. Now, there's kind of been a migration in the expectations. So it used to be you look at response rates, objective response rates, and all that kind of stuff, but with what's going on now with immunotherapy, kind of your expectations can change, and it's reasonable to do that because sometimes people have stabilized disease for a long time and they don't necessarily meet the criteria for response. So some of the current trials are looking at different endpoints than traditionally in the past. So their control was disease control rate at 12 weeks, which is a pretty short term actually for immunotherapy. And it was done, interestingly, 125 patients in about 6 months. So they did this quite quickly. Also interestingly, they looked at PD-L1 expression in these patients, and there was about 40% of patients that had PD-L1 expression, but only 2.4% that had what's considered high expression, which is greater than 50% on tumor cells. So you might not expect this to work in this patient population, but interestingly, it actually did. So I'm not going to go over all this data because I'm sure somebody else will later on. But the most important thing was that the disease control rate in the combination arm was better than the single arm with as high as 50%, and the median survival actually hadn't been reached, so it was over 15 months. So this is, and you think about this after chemotherapy, theoretically with a survival of up to a year or more. This could add potentially another year or more, 15 months on, so now you're getting up into the 20 months or overall survival for a patient, which is pretty significant. This is some of the responses that we're seeing. You can see there's thickening around the pleura here, and then with the treatment, with nivolumab, it just basically almost went away, but not quite. So there are other things that do support use of surgery. And I'm going to go over those really quickly. There's a historical cohort of long-term survivors. There's some effective treatments that have been developed that are advancing with adjuvants, new adjuvants in surgery. But also, if you think about it, if you're able to do even an R1 resection, you've essentially rendered the patient the equivalent of a complete response to chemotherapy because you can't see any residual disease after this, and that can be done in a period of time of 8 to 12 hours. So it potentially is actually most effective treatment at reducing tumor burden. So this is the ISLC staging project, which came up with the staging groups for mesothelioma, and you can see this kind of same tail I pointed out before, about 10% of patients with a relatively typical disease that survive long-term with surgery. And in the early chemotherapy era, this didn't really exist from the standard chemotherapy before. So this kind of group, you can hypothesize actually benefits from having surgery. So like I mentioned, surgery, even though there may be residual disease, is probably the most effective single agent to reduce tumor burden, if that's a very important thing. But long term, obviously, it has to be combined with other things like radiation, surgery, and potentially even immunotherapy. So we looked at our data a while ago. There's 121 patients, single surgeon, single institution, all having PDs. and looked at their pathological staging. 13% were actually early stage 1. The rest of them were stage 3 and 4. So they were pretty advanced tumors with only a small number of others. The pathologic findings show that the mean tumor weight that we took out, which I think is the best measure of tumor extent, is weight, which is 711 grams. We were able to do actually a complete resection. It is an R1 resection in 96% of the patients. Only 4% was residual disease, not without a lot of work. But we also look at margins at the end. Not really, we call them margins, but they're not really margins. So at the end of the operation, we go back and we take further biopsies from various areas looking for any obvious residual disease. And actually in 2/3 of the patients, almost there was no evidence of any disease you can see on those biopsies. Obviously, we don't check all the areas, but it just gives us an idea of how complete the R1 resection was. And then about a third of them, there was actually still residual microscopic disease seen at the margin. This was a survival, kind of plotted to kind of compare with David Sugarbaker's trial, and again, about 19.7 months, and we had the kind of philosophy that we didn't give chemotherapy right away afterwards because there was nothing to follow to see if they responded, and the response rate wasn't that great, so we delayed the chemotherapy until the earliest recurrence and then gave chemotherapy, and it turned out we kind of had the same survival as David Sugarbaker's tri-modality therapy, so we thought that was pretty reasonable. Okay, so some of the things that have been going on most recently of improving some of the standard kind of therapy, like the tri-modality therapy with a 19-month survival. We're actually working on other things that actually are going beyond that. So one of the things that people have been looking at and have published at least one paper on clinical trials of using betadine and water therapy. So this is kind of an old thing. Most surgeons kind of do this a lot in different circumstances without any data really. So we went to the lab and said we'd try to figure out whether this is actually something that would really work. So we looked at increasing doses or increasing concentrations of the betadine solution, which you just kind of pour from a bottle from 0.1% to 5%. And we actually looked at temperature because some people think that that's important. And you can see that there's a very good dose response. So as you increase the concentration, the number of cells, this is a log scale, by the way, too. This is not just 0 to 100, this is a log scale. So it's pretty impressive responses where if you get to 5% betadine, for about 10 minutes, all the cells die, pretty much. You can't detect anything left. So this is kind of impressive. On the other hand, it's also nonspecific. This is MSTO is one mesothelioma cell line, but it also happens in lung cancer and other things, and actually normal fibroblasts and other lines. So it's just a nonspecific therapy, but it potentially could help. But the temperature, the temperature didn't seem to make a difference until you get to above 43 to 45 degrees. So that'll come in just a second. So there have been a couple other in vitro studies that have been published that looked at kind of the mechanism. This was thought to be due to production of oxygen intermediates and mitochondrial membrane permeability changes. But it's kind of a consistent finding, and the cell death is often thought to be due to necrosis. This is a clinical trial a clinical experience that Louise Lang-Landusky published for 102 patients that underwent betadine therapy intraoperatively in a PD. So he used hyperthermia, 40 to 41 degrees, somewhere up there. And as like I pointed out in the previous slide, there's really no data that we can generate to support that, but it certainly wouldn't hurt. Interestingly, he had 68 patients who had N0 disease, so he had a lot of early patients, and he commented that he kind of has a practice that's really close to the shipyards, and that anybody from the shipyards that just starts getting a pleural effusion, they walk across and they see him right away, so he sees a lot of early patients. So he had good outcomes in terms of his surgical outcomes, and he reported a median overall survival of 32 months, which is obviously a lot better than a lot of other previous surgical reports, but again, 32 months compares with N0 disease in 2/3. Here's his survival curve, but the bar with surgery now is starting to move up into the 30-month survival range. So intraoperative PDT also is very, I think, interesting. I first saw this back in the NIH when I was there in 1986 when Harvey Pass was doing this. I thought it was a horrible operation because we sat there for about 18 hours and did this stuff. But I think Joe Friedberg had done a good job to develop this, and so he's published and actually updated this experience, but he's published doing PDT intraoperatively on his patients that undergo PD. He's used 2 different photosensitizers, which may or may not matter, and he also has a reasonably high number of advanced patients with 2/3 having N2 disease, so this is a different patient cohort than the previous betadine group. So his median survival that he's reported has been up to 36 months. This is disease-free and overall survival in the same graph, which is kind of confusing. So this is not a comparison of the 2 groups. This is just putting the 2 survivals on the same graph. So I think that PDT, theoretically and potentially practically can add something to mesothelioma surgery, but there's supposed to be an ongoing randomized trial, which I really applaud them for starting, although I understand that Joe Friedberg is now in Maryland and not participating with that trial, at least as of yet. This is some, I think, interesting. I've been interested in radiation for a long time. This is some data that I generated when I was in the lab back in 1989, I think, and it was looking at this immunotherapy issue where immunotherapy in animals, this is in B6, not B2 mice, with an MC38 tumor that was induced into multiple hepatic metastasis. And interesting because at that time we had to use Cytoxan or whole body irradiation in order for the immunotherapy to work. And the immunotherapy was IL-2 and tumor-infiltrating lymphocytes, which are in this column. And if you look at the 2 together, they didn't really do anything. There's 500 metastases or more in all the livers. If you do whole body radiation, then basically almost all the metastases are eliminated. So my question was, what if you radiated half the liver? So we basically took mice, anesthetized them, and shielded 1/2 the liver and radiated them, and then looked to see what happened. And this is one of the livers where you can see lots of white metastasis on this side and no metastasis on this side with the immunotherapy. So it was a very kind of a local phenomenon. So I think that kind of supports the use of potentially preoperative radiation, because that might actually help immunotherapy work better, or just the use of the combined modalities. So this is the SMART trial, which I think is a very interesting trial and is an ongoing one to experience. However, these are patients that are treated with radiation over a period of a week for 5 fractions, and then have to unfortunately go in EPP because the radiation dose to the lung is too toxic. And this is their experience, their staging, which is still, at least early on, was pretty early patients. And they had mostly, again, 96% were fully resected, and only 6% had an R2 resection, so that was pretty good. The mortality rate was respectable. This is the survival curve. Again, now we're in the 36-month range for median survival. When some subgroups, epithelial subgroup was up to 50+ months. So it looked like, at least with this trial and the betadine trial and potentially other things going on, that the bar with previous trimodality therapy is now moving as well for surgery. So this may be something that we have to now compare to what the current studies are with immunotherapy and other chemotherapy combinations. However, there's kind of this dual nature of everything. People are talking about surgery and no surgery. It doesn't have to be one way or the other. Surgery can be worked into some of the newer treatments and actually may be very successful in doing that. So there's some unique opportunities I want to talk about really quickly that surgery can potentially be used in. So these are just kind of thoughts and not necessarily data, but we're going to look at them. So there's some novel preoperative priming therapies that we could potentially use. There's some also intraoperative therapies that haven't been tried that I think may be useful, and then also postoperative therapies that we can kind of look at. So preoperatively, you can look at some potentially priming therapies that might add into the mix. And again, radiation is kind of one of them. If you use radiation, maybe the only thing that the radiation is doing is not necessarily killing the tumor cells, but by reducing T regulatory cells or other processes going on in the tumor, they may actually allow the surgery to induce the right immune response and kill the tumor by not only surgery, but by immunotherapy. And so there may be others. So this is the whole gamut of anti-mesothelin therapies, starting from the original PE38, SS1P, all the way through the vaccine. So what I'm interested in is using the vaccine, the doubly deleted Listeria monocytogenes vaccine, the CRS-207, potentially with surgery, which has not been done. So this is a study that was done a few years ago that looked at chemotherapy, 6 cycles of pemetrexed cisplatin again, and using the vaccine before and after chemotherapy, and it produced this waterfall plot, which is very favorable. Obviously, very few patients actually progress, and so the disease control rate was very high, and even the response rate was pretty substantial at 59%. So this was certainly better than the reported response rate for that combination by itself. So I think that this kind of supports the use of immunotherapy and chemotherapy together. But if you just potentially replace the chemotherapy with surgery, you could do the same thing with surgery potentially. This is just a report from the ASCO meeting earlier this year, looking at non-small cell lung cancer, but is looking at induction nivolumab. So this was kind of interesting, well, very interesting to I think a lot of people, because the waterfall plot also showed, so this is an interesting thing because you give the treatment preoperatively, you can take the tumor out and you see the response in a very short period of time, so you know whether your treatment's working and how well it's working. And you can see from here, this is 90% tumor necrosis, so there was 9 out of 21 patients that actually had what's called a major pathologic response, or more than 90% necrosis, which is quite impressive. It also calls into question whether surgery is actually necessary, if that's really true, but it just gives you an idea that these kind of things can be done before surgery, and then surgery can help also determine what the extent of the response. So this shows in that trial that patients who responded had a huge infiltrate of CD8 positive T cells that were theoretically helping to control the tumors. So there's some other novel priming therapies that we talked about, but including using potentially PD-L1, CTLA-4 immunotherapy. It works in other circumstances, so you could potentially use it preoperatively in mesothelioma as well. But also we can use some intraoperative therapy. So to go over that fairly quickly, because I only have 3 minutes left. You can use betadine water like I talked about, but there may be others. So, this is the amituximab anti-mesothelin monoclonal antibody, which does produce responses in patients being treated with it. The question is, if you have tumor left in the pleural space after you've done surgery, can you actually use this intraoperatively to help the immune system focus on the residual cells just by binding to them in situ? That's something that's not been looked at. The thing that I think we're interested in is this IL-4 receptor issue, which was kind of discovered by Raj Puri, who also was working at the NIH in IL-4 stuff when I was there, and he continued to be interested in IL-4, which to this point didn't really interest me until I learned about this, which was that IL-4 receptors are on different cancers. He looked at a whole bunch of different cancers and found about 300 to 3,000 some receptors on cancer cells. And you look at normal resting B cells and T cells, basically there's less than 300 sites per cell, so this can give you a little bit of selectivity in terms of killing a cancer cell. But the interesting thing is when he looked at mesothelioma, he found that there's 10,000 sites per cell. So this can give you a huge selectivity advantage. And they were high affinity receptors, so they bound IL-4 quite tightly. So we tested our patients, and they were all staining positively for IL-4 receptors, and 2 to 3 plus, and pretty positive, as you can see here. And then iropastin developed a fusion protein, which is similar to the SS1P, basically the same thing with a Pseudomonas exotoxin component that's bound to a circularly permuted IL-4 molecule. So this is a small molecule, not a monoclonal antibody, which does, I think, have some advantages. And it was tested in vitro and demonstrated a very high affinity for these receptors and actually minimal toxicity. So there's also a potential bystander effect, because when this toxin gets taken up into the cells are killed, and then they release the toxin again to be killing other cells. So it potentially can work at very low levels. So we did some preclinical in vivo experiments with murine tumors. This is actually our meso-1 tumor, which we generated from our our patients, and this is how it grows in mice really rapidly. It really takes off. And we treated with high and low dose IL-4-PE, which was done just on 3 doses, injected it into the tumor on Monday, Wednesday, and Friday after about a 10-day tumor development. And you can see that it dramatically decreases the tumor growth. And we looked at survival of mice, and the high dose IL-4-PE, that actually mice were cured long-term, because mice surviving 100 days is a pretty long time with cancer. So we saw these things. We were very interested in potentially doing a clinical trial. And currently, there's actually now GMP-grade IL-4 immunotoxin available for a trial, which we're trying to do. There is an ongoing trial also with the same toxin in glioblastoma in Texas, primarily, and in other sites, actually with John Wayne down the street from here. And we're interested in planning a trial for mesothelioma. So we're hoping to get FDA response by this spring about doing this kind of trial. What we're trying to do is actually use it intraoperatively, potentially, and perioperatively with a couple other doses immediately during the recovery period in 7 to 10 days, and see how it works. This is another kind of set of experiments now turning to temperature or thermal therapy. This is what I call a thermal print, and these are different cell lines. This kind of goes back a little bit to HIOC, or heated intraoperative chemotherapy days, and so we were interested in hyperthermia since I did that kind of research when I was an undergraduate, and I knew there was Chinese hamster ovary cells, which are pretty heat sensitive, and these are the ones that respond. This is a whole gamut of temperatures for different time periods, from 37 right here up and down below, actually even down to minus 80 degrees for up to 20 minutes, and heated up to 60 minutes. So as you can see, this cell line was pretty sensitive, dropped down. Again, this is a log plot, so it goes down a couple of logs with heating to 45 degrees. But as you can see about here, nothing happens below 43 degrees. So all the clinical trials with heated intraoperative chemotherapy and that kind of thing never heat up to above 43 degrees. So this would predict that the heat doesn't really help, at least directly. And all up here is A549, which is a lung cancer line, and there's 3 other mesothelioma lines which respond a little bit to heat, but not significantly, really. However, you look at the other end, the survival plummets when you get down to the freezing temperatures, which makes sense. That's one way to kill cells, is to freeze them multiple times in particular. And so the most sensitive cells down here were these are 3 of the lines of mesotheliomas, and this was the A549. So these were actually most sensitive to freezing, so we've kind of taken that into account. We've developed a few things. One is a clinical program to treat localized metastases or recurrences locally with cryoablation, and so that's been actually quite successful. We take a tumor like this where it's very difficult to treat, can't really do radiation to that, and if chemotherapy doesn't work, then you're kind of stuck. So we've actually just taken percutaneously in with probes and frozen those, and then afterwards they turn PET negative, and this is actually successful over 90% of the time at controlling these tumors actually long term. So we're also interested in actually extending this into potentially intraoperative use, because we have the whole surface of the inside of the chest exposed during surgery, so we potentially could apply some cryotherapy during the surgery. So we're trying to extend this into the perioperative or intraoperative area. So we've been developing a sprayer, which is not really available right now. There's sprayers that are available. You go to very tiny little areas, and to do the whole chest would be, or a lot of the chest would be very difficult. So we're developing a cryo sprayer that we can spray large areas with, and we're also trying to get a thermal camera to modify how much we do and to monitor it. So we're in the process of doing that. And also a kind of a thermofluorescence camera that can potentially see the tumor cells or see fluorescence in the cells that we can then aim for. So hoping to do that in the future. So you can see there's a lot of different things that potentially we can add to surgery, but what about postoperative treatment? So after surgery, I always thought it was kind of silly. You take all this tumor out, you know there's some cells left, and then eventually you just give chemotherapy and radiation or whatever you're going to do, and then you stop and you watch the patient, which didn't make any sense to me. So I've always been a proponent of doing maintenance therapies, because if you can slow the tumor growth down even a little bit, and when it's a small amount, then it potentially can make a difference in survival. So typically nowadays in non-small cell lung cancer and other tumors, as well as potentially in mesothelioma, you can use chemotherapy for maintenance treatments, particularly if they've responded to it, pemetrexed or bevacizumab or Avastin, but there may be others. So this is a report using alpha interferon as a long-term anti-angiogenic treatment for metastatic intracranial hemangioendothelioma, which is obviously a very rare tumor, but this patient had painful bony metastases which completely regressed on interferon, which I thought was kind of interesting. This is a report actually from Judith Folkman, who found a child who had a big tumor just destroying his mandible. And they had operated on this 2 or 3 times. It recurred, so it kind of sounded like mesothelioma in a way because it keeps recurring locally. And so what he tried is giving interferon alpha at low doses continuously, subcutaneously daily. And he was actually able to monitor the basic FGF in the urine. And it came down with treatment. And it kind of rebounded, and the tumor started growing, so he increased the dose of interferon, and it went down again to 0, and the entire thing regressed, and the mandible remineralized. So that was kind of an impressive thing that I thought could happen. And so I actually talked to Judith Folkman at a meeting, and I asked him about this, and he was pretty enthusiastic about it, actually. So I was thinking about maintenance interferon. This is obviously off-label from the FDA. It's not approved for this, but I thought it was kind of interesting to use. And so we looked at using up to 2 million units per meter squared subcutaneous daily postoperatively, which is what he suggested the dose from his experience. And what we did is we looked at 32 patients that were potentially eligible to have maintenance therapy after they completed all their therapy. This was just the information regarding them. They all had completed an R1 resection and 100% had radiation therapy afterwards. So we looked at how they did. There's actually very few side effects, although almost all of them had some kind of fatigue, which is hard to identify whether that's from all the other treatments or whether it's from the interferon. But we were able to maintain them pretty well. 3 of them had to have a dose reduction secondary to a little bit of neutropenia, which wasn't really life-threatening. And several of them actually had to have a stop due to depression, which is a real potential problem. But when we looked at the patients who had interferon maintenance versus those of our other patients who were not on that, again, this is not a randomized trial, so this is not a conclusion, but the interferon group had a 50-plus median survival. So it doesn't tell you anything, but it was kind of intriguing, and I talked to trying to get a randomized trial to do this. Unfortunately, it was not supported by the pharmaceutical company. They thought that they didn't want to do this. They had to just release the extended release version of interferon, so they wanted to use that, and I wanted to use at least the daily one because that's what we had been using, and we could do a comparison, but they just basically refused. So we haven't done that trial. So the other things you can use, the PD-L1, obviously, in current immunotherapy, you can add in postoperatively, which could be actually quite useful. I'll talk about more of that later this afternoon about how that may or may not work. But if you just kind of imagine in the future where somebody gets a mesothelioma diagnosis and you kind of figure out what you're going to do. So initially, one of our thoughts is you could use cryoablation, which actually kills a tumor, and you can just do a local area. And doing this actually produces a lot of antigen load. So if you do an antigen load and then provide an adjuvant, it could be listeria or some other adjuvant, and then add in maybe IL-2 priming, you could potentially prime the patient to have an immune reaction to his own tumor without having to go through anti-mesothelin or anything specifically. You could just use their own tumor to do that in situ. Then you could do lung-sparing surgery, and then during surgery, you could potentially do a lot of other things, which could include betadine. Very simply, it's what we actually do now anyway. You can use cryoablation after the betadine in water because the cells do swell when they get put in water, so you can then do cryotherapy because then they would burst easier, potentially, and you can add in potentially intraoperatively anti-mesothelin antibodies or immunotoxins, whichever you want. And I think what we were interested in is getting a somewhat depot preparation of IL-4 immunotoxin that can release the immunotoxin over a period of even up a week or so postoperatively. And you can do other things, gene therapy, CAR T cells, obviously a lot of different things, stem cells and oncoviral therapy. So all that can be actually applied intraoperatively when you have the tumor all exposed, and the opportunity to really have whatever agent you're using to really contact all the tumor cells and hopefully minimize systemic toxicity. Then afterwards, of course, you can do followed up with maintenance treatments with immunotherapy, potentially maybe PD-L1 therapy inhibition, because if you've generated the immune response, you can then upregulate it a little bit with PD-L1 and also continue maybe some vaccines as boosters. So theoretically, that could be how you might do something in the future, I think, if you really think about it. So in conclusion, the use of surgery is definitely decreased in mesothelioma due to a perceived lack of efficacy, although I'm not sure it's exactly true. There's non-operative therapies which also have improved in efficacy, but also surgical therapy has kind of been creeping up. So I think there's been creeping up in both treatments to better survivals, I think, and including better selection of patients, obviously. Immunotherapy is kind of an intriguing thing to add in, but I don't think we have a clue as to really what we're really doing. So I think we need to be smarter about investigating how to do it and using novel ways to combine them with other things, including thermal therapy, betadine, other things that may actually help patients in the future. So that's my talk. I think we have to proceed on with the next talk. Yeah, perfect, I'm on time. We'll have a discussion session at the end of the session. So we'll just go on to the next talk, which is being given by, it's Intercavitary Therapeutics for Pleural Malignancies, given by Dr. Olga Levsky, who's our chemotherapy oncologist for mesothelioma program at UCLA. She trained in University of Minnesota and then came down here to do oncology. She's been working with us for a number of years now. I can't even remember how many years, so it's embarrassing. But she has been key in getting our clinical trial program going, because I can tell you back in the 1990s and the early 2000s, before cisplatin and pemetrexed was approved, trying to get an oncologist interested in seeing a mesothelioma patient was almost impossible. I was mostly told, just go send them to the phase 1 person. So it's been a really pleasure having Olga on our team, because she actually is very interested and learns about it. So Olga's going to talk to us about intercavitary therapeutics. Olga.